So how this is going to happen, Giovanna and I are going to read the questions, and we're going to have the doctors answer your wonderful, great questions.
Dr. Yu, can you please clarify, does overnight fasting have to occur for at least 8 hours as recommended by ISI? That's the Interscience Institute.
Sure. I hope my table manner is fine, okay? Yeah. Most of the peptide hormones, usually the markers of pancreatic neuroendocrine tumor, as well as the chromogranin A, are higher after eating. So a fast of more than 8 hours often is needed and is desired. The worst thing is the random test, and then the results could be falsely elevated. For example, the pancreatic polypeptide can elevate it up to 20 times after a meal. So you can imagine it's a marker of a non-functioning pancreatic neuroendocrine tumor. So if you do that right after eating, it really can be very scary and make everybody panic.
Will PRRT be approved for foregut tumors? Peanuts.
It is unknown what the FDA is going to do. The company that manufactures the lutetium-177 dotatate is the Advanced Accelerator Applications Company. They have submitted a filing to the FDA for approval of this radiopharmaceutical as a new drug that will be available for treating neuroendocrine cancer. The randomized clinical trial, as you've heard extensively this morning, called NETTER-1, was designed for midgut tumors, which are basically almost always tumors that arise in the small intestine. However, there's maybe another 2,000 patients treated in Europe who have all kinds of neuroendocrine tumors, and we know from the European experience that it's also a good drug for tumors that might start in the pancreas or the lung or all kinds of other places if they have strong somatostatin receptors on their tumor demonstrated by imaging, like an arterioscan or a gallium-68 PET. So I think that the company is submitting it to the FDA, and then it's the FDA's decision whether to base an approval on strictly what is in the randomized clinical trial, which would mean approval only for midgut carcinoids, or whether they would go for the full approval for all kinds of neuroendocrine tumors. I think that I just don't know which way they're going to go, and the FDA is a little bit hard to predict. But I think there's probably an equally good chance that it'll be approved for other kinds of neuroendocrine tumors besides midgut tumors. But I can't speak for the regulatory environment.
Quick add-on to this question, and we have about 25 questions in 20 minutes, so let's try to 60 seconds a question. Once PRRT is approved, will it be limited to only 4 cycles? Question 1.
No. Once it's approved, it's hopefully not limited at all. I really believe, at least in Los Angeles, we'll have 3-4 sites. So all over the country, there will be many, many sites who can perform this.
Cycles.
Oh, cycles. Yes, first step will be only 4 cycles. This will be the FDA approval. But I'm very optimistic that later on we can do some additional trials to show that 6, even up to 8 cycles are feasible.
Okay, next question. Gallium-68 versus arterioscan. Do you guys, do the physicians feel it is necessary to have a gallium-68?
Yes.
Next question.
Excellent.
Okay.
Counterpoint. Yeah. Not necessarily.
Not necessarily. Good.
Whoa, whoa, whoa. When 2 Chinese doctors disagree, there's something wrong there.
It's pretty rare,
It depends on what you're looking for. If you need to prove that you have somatostatin receptors in order to have PRRT, if you have a positive arterioscan, that's all you need. You can go ahead and have PRRT. If you have a choice of the 2 scans, obviously you get the better scan, which is the gallium-68 dotatate. But I wouldn't say that it always has to be the only imaging to do for functional imaging.
No, but the problem is if you get an arterioscan, it's negative. What are you going to do?
A gallium scan.
Okay, next question.
Where is the gallium available?
Who loves gallium more than I do? There you go.
Okay. This question's for liver-directed therapy. Does bland embolization preclude a patient from PRRT or other future therapies?
From PRRT?
Or other future therapies?
Well, it certainly precludes you from doing radioembolization because with bland embolization, you end up blocking the artery. And you need that artery if you're going to be doing radioembolization.
I should mention that radioembolization does preclude PRRT in many centers in the country. It does not preclude entry into the NETTER-1 in the past or the current extension trial, which is open at UCLA, and we have it open at Montefiore Einstein in New York. However, if you have had radioembolization to the liver, it does increase the risk of radiation-induced liver disease when you have PRRT. And there are certain PRRT trials in America that exclude anybody who's had radioembolization. So I think nowadays, with PRRT becoming an important modality, you need to think very seriously about whether the additional advantages of radioembolization versus bland embolization justify the extra risk in the future of having radioembolization.
Okay, next question. Hindguts. These are often neglected and not enough research. Any suggestions on prognosis, treatment options, or any approaches for the patients? I know it's kind of general, but.
I don't mean to talk so much, but we like other people in the panel to speak
No,
as
that's
well.
okay.
But hindgut tumors have been less well studied than other GI sites of neuroendocrine cancer. Most of them nowadays are being found early and can be cured with local surgeries and local procedures because they are found incidentally at the time of colonoscopy. However, they certainly can metastasize and spread. There are a few differences from other carcinoids of the gut. One is that they tend to go to lung as well as to liver, whereas in the small intestine ones go primarily to liver. And brain. Secondly, they are less likely to produce any kind of hormones, and it's extraordinarily rare to ever see a carcinoid syndrome from a rectal carcinoid. And finally, the same basic concepts of treatment that apply to other kinds of neuroendocrine cancers apply to rectum as well, whether it's everolimus, whether it's PRRT in people that have somatostatin receptors, and other differences maybe we can talk about offline, but that's basically what I would think. Any other?
And for rectal carcinoids in general, you can, if they're less than 2 centimeters in size, we're just locally endoscopically, so through a scope, we're able to locally resect it. As if they're larger than 2 centimeters, then we obviously assess the issue of how far it is from the anus and whether we can preserve as much rectum as possible and not give someone a permanent colostomy. So it just depends. In general, if it's more than 2 centimeters, surgery is really where we start to consider a more formal resection rather than endoscopic resection.
I asked Dr. Kunz to join the panel. She's going to be speaking on immunotherapy, but there is a question right now. If you don't have the receptors for PRRT, what are the other options? Is immunotherapy an option?
So good question. I think it goes back a little bit first to, did you get the right somatostatin scintigraphy imaging, which was addressed earlier? So have you actually had a gallium scan? Because I've had patients who've had negative Octria scans and positive gallium scans to look at that. So if it's determined that...
She's so smart.
Yeah. So if it's indeed determined that there are no somatostatin receptors, then that's accurate. PRRT would not be recommended for those patients. There are a number of other systemic therapies, and it depends then on the grade of the tumor, on the primary site, and it includes things like chemotherapies, biologic therapies that were presumably talked about earlier today. Immunotherapy, I think, is very exciting. It's still experimental and not widely available, but I will, the teaser is I'll talk about that a little bit later.
Okay, great. A follow-up question or similar question. What research is being done or promising therapies that the panel is excited about for high-grade or poorly differentiated neuroendocrine tumors? Please comment on studies for high-grade NETs and thoughts on immunotherapy. I don't want to steal the thunder from the talk. But.
Okay. I'll start, and Ed's certainly welcome to weigh in. So there's currently a national clinical trial that's through the NIH that's comparing what is considered the gold standard, which is platinum etoposide for patients with high-grade neuroendocrine tumors. It's comparing that, like, so 50%, half the patients get that, and half the patients get temozolomide and capecitabine. So what has been frequently used for pancreatic NETs is actually thought to have some activity in high-grade NETs, much better tolerated in terms of side effects. So that's going on now. And I would say that immunotherapy in particular is very exciting for the high-grade NETs, and we're thinking of, I know a number of different institutions are thinking of looking at that from a cooperative group, National Institute of Health standpoint. We're thinking of developing a trial for immunotherapy for high-grade NETs too. Ed, any comments?
I agree with you completely.
Good answer.
There's another thing, somatostatin antagonist, which I've shown you before. This is something which could be really interesting for high-grade NETs. It's very early, but this is one of the things we are looking at.
I know there's also a radio-labeled conjugate, so an antibody conjugate drug. There's several in development, some of them targeting DLL3 overexpressing.
Yep.
I mean, if you're familiar with that data, so that might be also for the high-grade NETs. Some of these new types of conjugate therapies might be promising.
Yeah. If I can add one other comment, for patients that officially fall into the grade 3 with the Ki-67 over 20%, for some of those patients it's still recommended to consider getting a gallium scan to actually indeed see whether or not they do have somatostatin receptors. There's a rate, that cutoff is sort of arbitrary, and I'm actually using that some now to help determine biology. I'm getting an FDG PET and sometimes a gallium.
Actually, Rodney Hicks from Australia claims that the patient with the Ki-67 between 20 and 50% are the ones which benefit the best from PRRT. Yeah. But this is only hearsay. I haven't seen the data.
Right. And this same group typically responds rather poorly to normal high-grade therapy with platinum etoposide, and many of the other therapies used in neuroendocrine cancer are more appropriate, right, including PRRT, for sure.
Okay, this is a question for liver-directed therapy. Dr. Nissen said big tumors don't do as well with embolizations. How big is too big? Is it greater than 5 centimeters? Does it depend on location?
I think this question was asked last year too.
It's a good question.
That's a really good question. I don't really know. I don't think we have a cutoff necessarily, and it probably depends a little bit on the tumor biology of the patient. But probably, for ablation, once you get over 4 centimeters, it becomes a little bit harder to have an effective ablation. With embolization, probably maybe a little bit bigger, that 5-6 centimeters over that, it becomes, your efficacy decreases probably. But that said, I've had a lot of patients who have had giant tumors that we've embolized, and I think Mark Friedman as well, and we've completely eradicated the tumor. So. And had good sustained response. So it really depends.
Okay, this is another question. Can telotrestat still be effectively used when someone has had neuroendocrine tumor for a number of years and has progressive disease and uncontrolled diarrhea?
Go ahead, Ed.
Okay, the answer is most definitely yes. If somebody has carcinoid syndrome, which is not adequately controlled with the somatostatin analog, octreotide or lanreotide, telotrestat is a fantastic additional drug, has very few side effects of its own, and is very helpful. So I think that as soon as we have access to that drug, this is the perfect patient to get it.
Actually, if I could make a comment too, you have to make sure you understand the cause of the diarrhea. Right, so frequently people who have surgery have multiple reasons why they can have diarrhea. They can have small bowel bacterial overgrowth, they can have shortcut syndrome, they can have multiple things. So if you just throw it at it, assuming that's if it's from your carcinoid tumors because you have lots of metastases, then for sure I think that makes sense. And the other thing too is you have to make sure that the drug is being delivered correctly. So there are a lot of variables to it. You want to make sure that you make an accurate diagnosis for the diarrhea, otherwise it doesn't fix it.
Right, a great segue to this next question. Why do some NET patients lose so much weight while others don't? And what causes increasing weight loss in these patients?
I'll answer. That's a complicated question because there's so many causes for weight loss. If you take, for example, sometimes you have just overwhelming tumor burden sometimes. For example, if a patient has a really bad pancreas cancer, like the regular kind of adenocarcinoma we talk about or something else, they can have almost like a cachectic consumptive problem where they have no appetite. And that's kind of a different beast. When you have someone who has had multiple types of surgeries or adhesions or issues and they don't want to eat, that can be a problem. You can have people who have compromised blood vessels to their gut, and so they have pain when they eat. So it's multifaceted. So you need someone to really take a very, very good look at what the causes are to try to help with that. But there's no question that, nutrition, number 1, number 2, and number 3 are going to be kind of an indicator of who's going to do well and who's not. When patients have poor nutrition, no one does well because they can't tolerate their therapy, they can't have their surgery, they can't have whatever it takes. So nutrition is extremely important. I think you would agree with that. Yeah.
Can sandostatin exacerbate poor nutrition?
And sometimes it can, because sandostatin or any of the somatostatin analogs can actually reduce the amount of enzyme that comes out of your pancreas, and so you get something called pancreatic insufficiency. And we kind of traditionally think of it as, well, you get some greasy stools and smelly stools and things like that. I know for sure when a woman complains that her stools smell bad, that's a bad thing because, women don't eat and women don't fart. So whenever that happens, it's very, very serious. So, but it can be. So it's something that's very important. So you certainly need some kind of supplementation or whatever it takes, or even just modification of your diet. So working with a good nutritionist is also extremely important.
We've got a really good question here. I have had 250 millisieverts of radiation since July 2012. Can I still get PRRT?
Absolutely, yes.
Good answer.
I think that's a great question because a lot of people, and Josh did this at the SNMMI conference, are people keeping track of their radiation over multiple scans over multiple years? So this patient obviously is.
That's great.
We have a question on if the patient has been taking monthly sandostatin injections but continues to experience metastases, at what point is it considered sandostatin injections are not working, and should injections be stopped?
Oh, this is a good one.
I'll tackle this a little bit. So what degree of progression is truly progression, I think is actually a really good question of what triggers a change of therapy. So if the somatostatin was purely started just for tumor control, so did this patient have hormone symptoms? Do we know?
They did not.
Did not, okay. My practice typically is to stop it and then switch to something else. That is not universally accepted. And you could probably ask us all on this panel what our practice is. You probably get split answers. And so it actually would be reasonable to continue it and then add something on to that. And I can poll the group who continues versus who
I will continue.
Right. Actually, I would agree. Again, the 2 Chinese doctors agree. And the reason
so I will say no data for that.
What? That Chinese doctors are great. What I would say, the reason I do it is because neuroendocrine tumors are very, very heterogeneous, which means that they're different. They're like children. You can have, some tumors that are really well behaved and some tumors which are really particularly badly behaved. And I've seen this before in which you have, 12, 15 tumors. 11 of them are perfectly well behaved on the somatostatin analog, and that one is the one that's a problem. So, stacking it, I think, is good because it's kind of a combination therapy.
Yeah. My practice is to continue the octreotide or lanreotide. That would be my normal practice. There are certain exceptions to that. The reason for doing it is because, again, the heterogeneity of the tumor. But if you have strongly positive somatostatin receptors on scan, let's say your gallium scan shows that you have a positivity in the tumors, there's somatostatin receptors, you probably do help control growth in a fraction of the cells. The answer, though, is not rigorously known. We just, in practice, continue it most of the time in the same way that people with prostate cancer who are on anti-androgen therapy usually continue anti-androgen therapy even if chemotherapy is added later on for progression. It's a similar situation with neuroendocrine tumors. But if you poll experts around the country, there are many people who would respond exactly as Dr. Kunz, saying that it's not really worth continuing, which is the normal practice in oncology. If something doesn't work, you don't keep it up. And unless a formal trial is done to settle the issue, I don't think we're going to know. And I don't see anybody doing such a trial right now. So we really have a clinical judgment call.
But it's more complicated than that. I mean, I think the question that Dr. Kunz has said before is what is progression? What defines progression? So if you have one lesion that progresses, then you're defined as progression, right? You would be removed off trial or whatever the definition is. But in fact, for any individual person, if you have one lesion that's increasing and the rest of them are all stable, well then if you look at the whole kind of gestalt, maybe you're not as bad off as you think you are. Does that make sense?
And in 10 seconds or less, can you answer this question? Is there evidence to support the use of lanreotide for disease control in patients with Ki-67 of greater than 10%?
Well, the
10.
data, I mean, that's what the trial,
No.
less than 10%.
The Clarinet trial was done in Ki-67s up to 10%, and they made an artificial cutoff at that point, even though that's in the middle of the grade 2 range, which extends up to 20%. However, from what we know about the mechanism of action and also clinical experience, is that if people have a well-differentiated tumor, meaning the Ki-67 is up to 20%, and I would say even if the Ki-67 is up to 50% or 55%, if the gallium scan is positive, that it would be very reasonable to try using a somatostatin receptor attacking drug like lanreotide or octreotide as an anti-tumor drug. It has so few side effects compared to the alternatives, and if it works, can work often for years. You don't want to forego a therapy like that that's potentially effective.
Excellent. Thank you very much. We'll continue the Q&A.